My case is on heart failure. So this is a 47-year-old male with a history of atrial fibrillation on Coumadin. He's got end-stage renal disease, on hemodialysis Monday, Wednesday, and Fridays. He's on insulin for diabetes. His EF is really crappy, 10 to 15%. And there is something written in the chart about the patient having some unrevascularized coronary disease, and he presents with, after 2 days of missing his dialysis session, with worsening shortness of breath over the past 5 days. So you can see his filling pressures. His right atrial pressure is 16, his RV is 75 over 12, the PA is 75 over 33, and most importantly here is the pulmonary capillary wedge pressure, which is 38, and he does obviously have high cardiac output. So what do? Case is done. It's moderate lesion in the LAD, optimizes heart failure meds. Now, technically, if I want to, I can just stick a stent in it, because according to the appropriate use criteria, in a patient with an EF of less than 30% with even a moderate lesion, I can stent it. Or maybe I should be evidence-based and assess the FFR, or maybe I should image it because I like to image it, and I'm a believer in the plaque. So those are my options, right? So, I decide to be evidence-based, and I do an FFR, and it's 0.90. And then this is the final angiogram afterwards, and I'm kind of done. But just before I'm about to close up, I'm like, it looks kind of tight. Something's not, right. So, it looks kind of tight. What should I do? So I decide, what I'm going to do? I'm going to image it. Okay, so we do an OCT run, and this is what it shows. So as you can see, completely normal trilaminar appearance throughout, and a little bit of neointimal hyperplasia, some fibrous tissue. Really pretty healthy. Not looking so bad. Not bad. Okay. All right. Whoa. Okay. Whoa. It's pretty tight. It says LAD. The EF is 10 to 15%. There's his previous stent. So this is somewhat in segment. So that's pretty tight, right? So I'm trying to decide, what do I do now? The lumen area is 1.99. There's plaque there, but the FFR is completely normal. Now, what you remember here is the FFR, the RA is 6, the RV is 75 over 12, the PA is 75 over 33. So these numbers are pretty high. So the question is the FFR valid in overt volume overload? We're not really sure. So I literally during the case, I asked the fellow to run outside and we look up the evidence. Okay, we find this paper. And this paper says that in a high LV EDP, it may impair the myocardial blood flow by increasing the coronary flow pressure, coronary zero flow pressure. What that means in English is that the FFR increases by 0.008 for every 1 millimeter mercury increase in the LV EDP overall, and 0.004 if the FFR is less than 0.80. Okay, so here's my math, right? So 0.91 minus 38 LV EDP minus 20 LV EDP, which gives 18, multiply that 0.008, that's 0.76, so I should just stent it now, right? So what do? Leave it, FFR is negative, stent it, the FFR calculation is positive, stent it because it's tight, or be Ziad. So I chose to be Ziad, so I asked the nurses to hook him up to IV sodium nitroprusside and bolus him with 120 milligrams of Lasix. He still urinates, okay? And then I wait for 30 minutes. These are the numbers. Wedge pressures come down beautifully. RA is now 8. And I'll repeat the FFR, and what do you think? It's exactly the same.
Shit.
Exactly. Okay? So, I'd like to thank you for your attention. But wait. Okay. Comes back to clinic 1 month later. He's discharged and volume optimized by a hemodialysis, and he's still short of breath. And so then during our consultation, nice guy, not the most educated guy, he tells me, Doc, I got another scan from Dr. So-and-so. And I'm like, who's that? And he goes, oh, that's my doctor at Montefiore. It's like a hospital in the Bronx where he lives. So I'm like, okay, what scan was it? And so he has no idea. So he says something to do with my heart. So he undergoes a PET stress viability. And Niels is in the audience, so we'll be enlightened on this. So now it shows severe ischemia in the LED distribution and all the territories are viable. So someone else had seen this. Remember when he told me he had unrevascularized coronary disease? He basically told me I have a narrowing in my artery. That was his Montefiore doctor sending him to determine whether he was ischemic or not. So he comes back for coronary angiography with an LV EDP now of 16. These are his filling pressures, okay? And we do an FFR. .76. It's literally the calculation that we had done earlier on. Why is the FFR now positive? I did the testing. I brought the wedge pressure down. It was totally negative. And now his FFR is 0.76. And, I'm pretty diligent with making sure that you get hyperemic and that the patients have the response. And we have a pretty good protocol. And so in the end, we ended up putting a stent in using OCT guidance. That's the OCT guided PCI. That's our distal reference. We implant a stent. Nothing really excited about that. And then this is our sort of final image. So I'm going to end with that. And so leave you with some thoughts. It's just showing good expansion. So the thoughts are, acutely dropping the left ventricular end diastolic pressure does not allow for microcirculatory recovery. The way I kind of envision this is it's like a swamp, right? You're completely overloaded. Even if you dry the patient out and you shift some of the fluid out and acutely bring down the LV EDP, you're still in a swamp. And so what this patient needed was a period of dialysis to actually dry out the microcirculation for it to sort of subacutely recover. Can these patients be managed medically or to bring down the filling pressures prior to PCI? I think we should always do that. He got lots of hemodialysis before, and this was completely unbeknownst to me that he was having this CT scan. So in borderline FFRs, we may be an overestimate due to high left ventricular end diastolic pressure. Of course, this is also controversial in aortic stenosis, and lowering the LV EDP over time for microcirculatory recovery may be necessary. Thank you very much.